Thank you, ladies and gentlemen. Now I think I'm all right. As a prelude day,
your due date is calculated from the first day of your last menstrual period. Conception occurs about 2 weeks from this day, and that's when you're truly considered to be pregnant. During a menstrual cycle, one of your 2 ovaries matures an egg within a follicle. Hormonal surges controlled by your brain then cause 1 and occasionally 2 follicles to release an egg. If both ovaries release an egg, you may have non-identical twins, also known as fraternal twins. Long, finger-like projections sweep the egg into the fallopian tube. The egg travels down the fallopian tube, pushed by tiny hairs. It awaits the arrival of sperm. About a teaspoon's worth of semen enters the vagina, containing roughly 300 million sperm. Less than 100,000 will pass into the cervix to begin their 6-inch journey to the egg. A long, whip-like tail propels each sperm toward the waiting egg. Most sperm will lose their way. Only about 200 sperm successfully reach the egg. Fertilization occurs when 1 sperm penetrates the egg, combining their genetic material. The sperm and egg each contain 23 chromosomes holding all of the information that determines your child's sex and contributes to the child's genetic makeup, including physical appearance, intelligence, and personality. It's a boy or a girl. You just don't know which yet. Within 24 hours of fertilization, the egg, now called a zygote, divides into 2 cells. The number of cells doubles about every 12 hours as the zygote continues its trek to the uterus. During this early stage, cells split into 2 separate groups. Instead of remaining attached, you'll be doubly blessed with identical twins. About 3 days after fertilization, the zygote has become a ball of 32 cells resembling a miniature raspberry. A few days later, it reaches the uterus as a ball of roughly 500 cells surrounding a fluid-filled cavity. On day 7, the ball of cells burrows into the uterine wall during a process called implantation. Many women have implantation bleeding or spotting at this time, which occurs about 21 days after a period, before a pregnancy test could even be positive. The cells on the outside of the ball create the yolk sac and the placenta, which nourishes your developing baby. By 38 weeks, the fertilized egg has grown into an infant with more than 2 trillion cells.
From up to down.
Ladies and gentlemen, just mute your microphones, all of you. Just mute your microphones. We are starting. My name is Dr. Mahapa. This was just a prelude to show you what fertilization is all about and fertility is all about. I request everybody to mute his microphone. If you see me asking you to mute your microphone, just mute it. Once more, good evening. Talk today is about female infertility. The last time we discussed male infertility. If I ask you to mute, please just mute. Otherwise, I remove you. Because I can see this side if you who is talking. If I ask you to mute, just mute. We're talking about infertility. What you see here is the inside of a woman with an ovary, the uterus. That's where everything happens.
Oh, Toddy, what shall we do? Sinzinjan,
what shall we do?
This was just an introduction. What is infertility? When you talk about infertility, what do we mean? We mean infertility basically is defined as failure to conceive despite regular unprotected sexual intercourse over a specific period. That period is average 12 months, which inability to conceive, to become pregnant over a period of 12 months is regarded as infertility. If a couple has been engaging in regular unprotected sex over 12 months and without any conception, that couple is regarded to be infertile. In general population, spontaneous pregnancy is expected to happen in 80% of couples after 1 year of unprotected sex. After 2 years, almost 90% of them will be protected. So there are many things that can cause infertility. This definition, it doesn't mean that when you go to the doctor, you haven't spent 12 months of unprotected sex, you will not find you as being infertile. There are exceptions to the rule. Exception is that you must look at the age of the couple. If the couple is a bit elderly, you should take into consideration that they've been trying whether in other relationships, or if you find any identifiable cause of infertility. For example, you find a woman with a huge multifibroid uterus with endometriosis, polycystic ovarian disease, many conditions, then you regard that as infertile initial. So it doesn't have to wait for 12 months. Like, for example, if a woman has got multiple fibroids like this one could just determine that with fibroids like this one, you wouldn't be able to fall pregnant. Fibroids need to be removed for a woman to fall pregnant. But sometimes on examination, on ultrasound, you find a woman with previous pelvic infection which has damaged the tubes. The tubes has got hydrosalpinges, they've got water inside, they're blocked, and they're thick, inflamed, and thickened. That tubes, you know, that because they are blocked, they won't be able to enter those tubes. Not only the hydrosalpinge is the cause. You find that sometimes a woman here comes with chronic pelvic pain on intercourse. And when you do another ultrasound or another examination, another laparoscopy, you discover that she has got grade 3 or grade 4 endometriosis. In that way, that woman is regarded as being infertile. As you see on the left is hydrosalpinge, on the right is severe form of endometriosis, which the treatment thereof will not be medical, it's just the removal of the entire tube. And the woman on the left can only conceive through assisted reproductive technology, which is called in vitro fertilization or IVF. More often, when the women come for examination, you find that during examination, certain clues can be found that can lead to infertility. For example, on ultrasound, one can see a cyst in a woman who presents with irregular menstruation, who present with chronic pelvic pain during intercourse. And that cyst, if it examined laparoscopically, will be found. And more often it can be just a follicular cyst. It can be endometriotic cyst, like you see this endometriotic cyst here. It's got chocolate cyst, chocolate coming out. Endometriotic cysts that come from endometriosis are called chocolate cyst. Usually, the infertility investigation, one should really examine the genitals thoroughly, make sure that, because that's where fertility is going to take place, to make sure that everything is fine before you can say start treatment or give the patient a false hope. Like a woman, big cysts like this, whether functional or not, they'll disturb some way, disturb anatomically or physiologically, they'll disturb conception. Because if they're like this anatomically, they'll push the tube away. You won't be able to pick up the egg if it ovulates. But if it's producing hormones, the hormones will disturb the menstruation. But infertility in itself is classified by World Health Organization as a disease. Infertility is a disease which can be caused by many conditions. We discussed male infertility last time, where we discussed several types of disorders. In female, there can be ovulatory dysfunction, a decrease in ovarian reserve. As you age, your ovarian reserve decreases. Some women have had operations on the genital, on the ovaries, maybe one ovary removed due to a cyst or a pathology of the ovary, like a tumor, or abnormal mucus. Many things can cause infertility. If infertility, after investigation, you can't find any cause of infertility, we regard that as unexplained infertility. There are women who are infertile, but cannot find what caused infertility there. In all the investigation, you don't know. That's what we call unexplained infertility. Those women with unidentified factor that lead to their infertility. If a woman, a couple, has never had previous pregnancy, either any of them in previous relation or in this relation, that infertility is said to be primary. It's primary infertility. But sometimes you might find people who come, they have had pregnancies before with live babies, without live babies, with miscarriages, but now they are finding it difficult to fall pregnant. Those women are regarded as secondary infertile. They've got secondary infertility. The etiologies and causes may differ. If couple comes with infertility, I say couple because infertility is a disease of a couple. It's not a disease of a woman. There's this notion in African that when there's childlessness in the family, blame is put on the woman. That's not true. Infertility is a disease of a couple. We take a history, and the history of infertility can be intense. Sometimes can be embarrassing because some of the questions that you have to use some diplomacy, because there are some questions that you can't ask the woman in front of the husband. Same as if you want to assess for male infertility, there are some questions you can't ask in front of the wife because they are very embarrassing conditions. So infertility can lead to a feeling of sadness, frustration, and anger in a woman, even guilt, resentment, and a feeling of inadequacy. A woman with the infertility, she has got all this psychological problem that she feels inadequate. She feels she's less of a woman. I must approach her with some compassion, diplomacy, and empathy. Some women, not every woman who comes for infertility will be helped. Of course, there are those that you can't even help at all. But the way you relate with them and the way you relate the information, it shouldn't be such that you diminish the woman. Like, for example, if you've got a woman with severely damaged tubes, there must be a way to tell her that I think it would be important, not possible for you to fall pregnant through the normal, and so that you can be able to refer her to assisted reproductive physiology. Same with these huge fibroids that you think the treatment is the removal of the uterus. Then we need some form of diplomacy to tell her about that. Even when you take marital history, and sexual history, and social history, questions should be tailored depending who is in front of you. That's why I decide to see the couple together and call each an individual alone to get some more information, to get that information that woman could not tell another woman. For instance, woman has had previous 2-3 miscarriages while she was still a student, and now she's got married in this relationship. The husband doesn't know of those 2 miscarriages or just abortions. You can't ask her in front. She won't tell you. Same as a man. An examination of an infertile woman is any other gynecological examination. It is very intrusive. You must be made in such a way that the human dignity is restored. When findings are found, it's not findings that one should just exclaim in front of her and say, oh, big fibroids. No. You get the clinical information from examination and know how to relate them well in such a way that human dignity is relayed. The investigation can be wide. That's why women should be counseled that we can take blood after blood looking, because sometimes it's permutation. You assess this, you don't find it, you take blood for this, you don't find it. Investigations can be very wide before you find the cause. And some of the investigation, of course, can be very costly. In summary, when approaching infertility, it's a disease classified by World Health Organization, one should approach with diplomacy and empathy. Because most especially on a woman or a whole couple, it's a disease that they expect something positive. If you cannot, there's no positivity coming out. The way you relate it should be in such a way that the hope can be there, because with assisted reproductive technology these days, every couple can have pregnancy. Except that it's a bit costly, but it's possible. Statistically, 70% of couples will conceive after receiving some form of treatment. Only 30% will remain childless. In any population, about 40% of infertile couple, there's a male factor contributing. The other 40% is female, the other 20% is both. And one about the effect of age. one should not wait till late to start infertility treatment because fertility reduces very greatly after the age of 30, 40. But the older you become, the fewer the number of eggs, the less fertile you become. So the younger the couple, the better. If the couple is old, information that you are too old, you should not just be relayed in such a way that it breaks their hearts. There are couples who are old enough who can even have pregnancy and even have twins. You don't give up. We never say never in medicine. The older the person, the more the chances that it will be difficult to have a baby. But I'm not saying it's not possible. It is possible. So don't kill that hope. What is conception? For a woman to fall pregnant, there are things that must happen. There are certain things that must happen. There must be intercourse, which takes place around the time of ovulation, around the time when the egg is released from the ovary. Release of an egg from the ovary is called ovulation, around the time of ovulation. So the ovulation cycle of the woman should be studied either by basal body temperature. Nowadays, there are apps on the phone that can track ovulation. There are, in the chemist, you can find ovulation keys that woman can know which time they ovulate. Most especially with the present work situation where people are migrant, husband and wife are not working in the same place, must make a means that around the time of ovulation, they do make love. The system that produces egg and sperm must be working. The ovulation, the hormones must be better, must be in such a way that she can ovulate. An ovulation test is one of the easiest tests that the woman can do himself at home. So, which means what I'm saying is that the hormone must be balanced so that she can ovulate. During the egg formation before ovulation, there's a follicle that develops as a small primary follicle, and it grows, and it becomes a Graafian follicle, which about day 14, it matures and ovulate. This can be tracked with ultrasound, whether this is growing. And if once you have a leading follicle of about 12 millimeters, you can tell the couple that even the husband is working in Gauteng, try to meet around that time. You're given the chance of conception, provided other things are normal, is the distance that disturbs the couple from being pregnant. In our population, there are many causes of infertility. I'll just discuss few things. The topic infertility is so huge that I can't cover it in one lesson, but I try to choose here those that are common that I see most especially in my practice. I try to make this talk more visual than notes because you're not going to write the exam on this, so make it more visual. Ovulation disorder. There are many causes of anovulation, from stress-related, hormone-related, disease-related, medications. There are many things that can cause ovulation. The ovulatory status of a woman should be assessed and be normal. And the second one that is caused that causes infertility is tubal damage. Tubal damage, more especially by pelvic inflammatory disease. Pelvic inflammatory disease, and which arise from firstly as vaginal infection, is one of the causes of infertility that we find very real. That's why no woman should take vaginal discharge lightly. Every vaginal discharge must be vigorously, because if it ascends through the cervix into the uterus, through the tubes, and cause pelvic inflammatory disease, it might cause irreversible tubal damage. Because I've just said that after 35 years, the chances of conception are less, and the coital frequency, it becomes less the older you become, both in men and women. So there are conditions like endometriosis and pelvic infection. Endometriosis, you can't prevent it, you can't predict it. If you had it, it's hard luck. But if discovered early and treated, outcome can be good. The ovulatory disorders, said is one of the commonest causes. It is classified into 3 categories. The disorder that the problem is in the hypothalamus, in the higher center, in the brain. Or other disorder that category 2, the problem is in the pituitary. Pituitary gland is the gland at the base of the skull, which also is responsible for the hypothalamic pituitary gonadal axis, which produces hormones. The last one is ovarian failure, problem with the ovary. Category 1, as I said, caused by the failure of the hypothalamic to function, release hormone that triggers the pituitary, and the pituitary will release the hormones that will trigger the ovary ovulate. Low basal gonadotrophin and ovarian steroid. Gonadotrophins are those hormones that are produced by the pituitary. If the gonadotrophin are low and ovarian steroid are low, then there won't be ovulation. And such women usually will have hypothalamic amenorrhea. They'll have no menstruation. A woman coming without any menstruation, we know that she doesn't have ovulation. She's probably having a problem in the pituitary or in the hypothalamus. This is a scheme of hypothalamus in the brain. It produces releasing hormone, which is called gonadotropin releasing hormone, which acts on the pituitary, especially anterior pituitary gland, which releases the gonadotropin, which is follicle stimulating hormone and luteinizing hormone, which are going to act on the ovary, release ovarian steroid, which is mostly progesterone and estrogen. This is the axis of which is called hypothalamic pituitary gonadal axis. Once you've got hypothalamic dysfunction, pituitary dysfunction, they are called normal gonadotropic ovulation. They don't ovulate besides having normal gonadotropin level. This category of women are women with hyperprolactinemia and women with polycystic ovary disease. You take the blood, you find that gonadotropins are normal, but she's not ovulating. And with polycystic ovary disease, one thing that can make it true is that she's got irregular menstruation or she's unovulated, unovulatory. She doesn't ovulate at all. And you can see tiny multiple cysts all over the ovary if you do an ultrasound. And this usual cyst that either in the periphery or they can, the entire field of the ovary can be full of cysts. If you do androgen levels, the androgen levels are usually high, more especially testosterone is high. That's why they've got virilization. They develop hairs, they develop beards, they develop voice changes. They've got some virilization with clitoris become a bit larger, but it can't be as large as the penis. And the issue, they are always insulin resistant. We expose them to diabetes in later life. If you take insulin level high because they've got insulin resistance. If they are obese, it's worse. Polycystic ovary disease is not obese, is better to treat than obese polycystic ovary syndrome person. This is the picture of an ultrasound of a woman with polycystic ovary. She's got a lot of small little cysts in the ovaries. And if I want to do an animation thereof, it will be ovary with small little cysts, which are more than 10 on the periphery of the ovary. No, they are never more than 2 centimeters in diameter, but sometimes they can fill up the entire ovary. The other thing that you can see here, the presence of beards. Maybe 1 or 2 beards, or the entire chin might be full of beards. And if we look at the escutcheon, distribution of the pubic hair, it's got male type of distribution of pubic hairs. You know, male has got a diamond-shaped type of pubic hair from the navel right up to the pubis, while a female has got an inverted triangle type of pubic hair. It only goes up to the upper part of the symphysis pubis. So it's got the hair even going up to the stomach. Sometimes can have hair even on the chest like a man because it's got increased androgens, which are male hormones. And androgens tend to cause acne. So I've got more acne in men than in women. We have acne vulgaris. I'll later at the end of the day show you how to treat this very seriously. Although it can be treated medically, surgically can also be treated. One thing that I discovered is that there's a fashion these days that people must be thin. Be thin is fashionable. Extreme of weight, be extremely overweight, or be extremely underweight will cause anovulation and infertility because you need a certain acceptable level of adiposity in the body for you to have a good metabolism of hormones, mostly production of ovarian steroids. Mustn't be too thin, you mustn't be too fat. There's a condition called anorexia nervosa. Another condition is called bulimia. Bulimia will cause you loss of weight. These are women that it's a psychological problem that women eat, and then suddenly she induces vomiting and vomit all the nutrients such that she loses a lot of weight. We don't say people should be, women are very proud of being thin because thinness is in fashion now, but thinness is not always physiologically correct because it can cause to ovulation, especially if you are extremely thin. The thing that is fashion is you are a beauty queen, you will have anovulation, have difficulty in conceiving. So once you have got a tendency, or you have got a psychological problem called a dysmorphic disorder, you want to see yourself in a certain fashion, you're not satisfied the way you are. It's good to exercise, be fit, but not to exercise besides that you become very, very thin. Because most especially if women come like this, they need psychiatry to see whether they don't have an eating disorder that causes severe and strong fear of gaining weight, which is called anorexia nervosa. Many women around who are thin, they've got this condition undiagnosed. While bulimia, although is not so common, it's an eating disorder characterized by uncontrolled episode of overeating. Eat all the time. He passes next to the fridge, he opens, he eats something, he binges something. Then thereafter is followed by an episode of purging, that just causing vomiting, putting a finger inside meat, and even take laxative and take all those food out. That's a eating disorder, which is psychiatrical. Many doctors cannot diagnose psychiatric diseases. So it's important that you find such a thing, get a psychiatrist and see whether you're not dealing with a psychiatric problem. Second category is hypothalamic disorder. The only one that I want to discuss is what they call hyperprolactinemia. A woman who has got increased hormone called prolactin. This hormone prolactin is produced by posterior pituitary, and it's a hormone that when a woman is breastfeeding is responsible for breast milk production. So if a woman is not breastfeeding and is not pregnant, has got milk production secretion from the breast, chances that we suspect the first in the suspicion is increased level of prolactin, which is from the pituitary gland, which is sitting at the base of the skull here. This is a magnification of Salatusica, which is the trough where the pituitary stays on the base of the skull. It produces prolactin, but other things also can produce hyperprolactinemia, like ordinary stress, psychological stress, chronic stress. Executive women nowadays are taking executive position, which has got so much stress with them. Toxic relationship can cause much stress. Financial things can cause much stress. If a personality wants to achieve more than he can cause much stress. Sometimes you can have a tumors in the pituitary. If they are very small tumors, less than 1 centimeter in diameter, it's called microadenoma. If they are more than that, they are called macroadenomas. They can also produce prolactin and cause galactorrhea. Galactorrhea means release of milk from the breast outside the breastfeeding session. Some medication, mostly antipsychotic medication and some antihypertensive medication, can cause increase in prolactin level and cause breast milk secretion, and thus cause an ovulation, ability to ovulate. And then drugs, those who are using opiates and cocaine, they are very notorious of causing hyperprolactinemia and causing ovulation. That's contributing to infertility. Of course, some other diseases like liver disease and thyroid disease, which are hypothyroidism, can cause amenorrhea, which is a result of increased prolactin secretion together with galactorrhea. Amenorrhea means lack of menstruation. And find that the woman, when you express the woman's breast, white milk comes out. And most women, my experience is that I realize that They are not aware that they're secreting milk. You ask them, we've got a woman coming with menstrual irregularity. You ask her, you secrete anything from the breast? She says, no. It's okay, let's see. Try to express from the breast milk. For the first time, she realized that she's secreting milk from the breast. This is quite treatable. A lot of medication out there that can treat hyperprolactinemia, except when there's a microadenoma, you need surgical treatment. Category 3 is ovary. If ovaries fail, ovarian failure is a disaster. If ovary fail, they fail. That's why premature ovarian failure, some people regard it as premature menopause, but it's not premature menopause per se. If you see by high level of gonadotropin, FSH and LH will be high because and knows ovarian steroid to cause negative feedback on them. It's low estrogen and low progesterone. The women with ovarian failure in this category can only conceive through egg donation. Once you've got ovarian failure, it's ovary are failed. There's nothing you can do except egg donation, IVF treatment with donation, because ovarian failure is not something that you wish to find in a patient, because if it's there, it's regarded as premature ovarian failure, and there's nothing that you can do. Let's take it through what fertilization is all about. You know that egg ovulates from the ovary. It meets the sperm in the fallopian tube. This egg which ovulates from the ovary is picked up by the fallopian tube with finger-like processes like fingers of the hand, which is called embryo. And then the sperm enters from the vaginal side, where it's deposited from the vagina, and enters through the cervix into the uterus, and it meets the egg in the cervix. They meet the egg in the tube, and fertilization takes place in the tube. Once the fertilization takes place in the tube, it must move from the tube. It must move now from the tube and go inside the uterus, where it's going to implant, where the baby is going to occur. Should anything happen that disturb this fertilized egg from moving quickly to the tube, it must reach the uterus by day 4, day 5. If by day 4 and day 5 the egg movement is slow or movement is disturbed, it's still in the tube, it will implant there because that's the time for implantation. And if it implanted the tube, there's no room for growth here. This tube will burst. That's how ectopic pregnancy occurs. If maybe explanation, if it's not very clear, this can explain it better.
While you release only a single egg each month, your partner releases millions of sperm in a single ejaculation, all with an eye on that single prize. But only one of those sperm will be crowned the victor. As soon as one lucky sperm cell succeeds in penetrating the egg immediately undergoes a chemical reaction that prevents other sperm cells from following suit. Then the chromosomes carried by the sperm and egg come together, and the egg is officially fertilized. The fertilized egg then begins a rapid descent to the uterus. Over the next 7 days, the human embryo undergoes multiple cell divisions in a process called mitosis. At the end of this transition period, the embryo becomes a mass of very organized cells, called a blastocyst. Once the embryo reaches the blastocyst stage, approximately 5 to 6 days after fertilization, it breaks out of its protective covering and begins the process of implantation in the uterus. To find out how your baby grows and develops,
I hope this explained very well. As I said, infertility is a wide topic. You can approach it from any side. I decided in this presentation, I'm not going to, you can run the whole symposium for the whole week about female infertility. We'll never finish it, but I've decided I'm going to run it regionally. I'm going to start with vaginal condition that causes infertility, cervical condition that causes infertility, uterine condition that causes infertility, the conditions of the fallopian tube that can cause infertility, conditions of ovary that causes infertility, endocrine problem that causes infertility, genetic problem that causes infertility. That's how I'm going to decide this. I'm going to run it like you can run it any other way, but you can never finish it. A condition that prevent or limit sexual intercourse. the vaginal conditions. You know, for fertility to happen, there must be sexual intercourse in the vagina. There's a condition called vaginismus. Vaginismus is involuntary contraction of vaginal muscles. Immediately penetrations that occur, the vaginal muscles just go into and clasp and close the vaginal introitus. So such couple, if the woman has got vaginismus, will never have penetrative sex. So in that way, it's cause of infertility. It's important to ask whether the sex is penetrative or not. Vaginal pain, chronic vaginal pain, superficial or deep vaginal pain, deep dyspareunia. Dyspareunia means painful sex. Will limit the frequency of sex or may even prevent sex at all because the woman has got vaginal pain from whatever cause. Might be endometriosis, might be infection, might be a septum, might be anything. Ask whether there's painful intercourse. If there's painful intercourse, you must know that there's a mutual love between the couple. No man can force to have sex regularly with a woman who has got vaginal pain. The hymen, some women are born with a very thick, hard hymen, such that it usually becomes like a septum or an operculum that closes the vagina. You will examine and find that the hymen is not completely torn. You must know that the sex is not penetrative. Vaginal septum can be different. It can be transverse, can be longitudinal. If it's transverse, it will block it will act like a barrier between the egg and the sperm. Sperm won't penetrate through them. Even if it's high transverse, they can be satisfactory sexual intercourse, but there's no meeting of sperm and egg. Usually, these women also present with other things. They present with what you call amenorrhea and hematometra. They menstruate inside the uterus, so that they'll have large uterus which contains menstrual blood, because menstrual blood doesn't come out. Every month it accumulates inside the uterus. That you can suspect that they've got a high vaginal septum. Some women, very rarely, we can find them with a condition called Mayer-Rokitansky-Kasser-Hasser syndrome, which is a mullerian abnormality where there's absent uterus, absent cervix, but they've got fallopian tubes, they've got ovaries, they've got normal cycle, but they don't have a uterus. The same variant of mullerian abnormality we can find in a woman with a condition called testicular feminization syndrome or androgen sensitivity syndrome, in which case a person is genetically a male, but phenotypically is a female. We discuss that later. But several mullerian abnormalities that can happen. But the vaginal conditions, septum, I've said that can be low septum right at the beginning, like a hymen, which is pussy, can be mid-vagina, can be high. If it's high, I've said there can be penetrative sex, satisfactory, but the menstrual blood from the uterus will not come out through here. So it will accumulate in here and call a condition called hematometra, which hematometra means blood in the uterus. Or the septum, if this is transverse septum, if it's longitudinal, it can divide the vagina into two portions. You find that the woman is like she's got two vaginas, but she's got two canals. So one canal, more often, you find that both canals can communicate with the cervix. So whichever compartment sex takes place, the sperm will be enter there. The unfortunate situation would be in the coming. This is showing what the hematometra is. If you've got transvaginal septum, the blood will accumulate there, which need to be taken out. The unfortunate situation would be in a situation where the septum is divided the vagina into two. The uterus is also divided by a septum, the vaginal septum, into two conus. This will not cause infertility per se, but it might cause pregnancy losses because the uterus, which has got a septum in between, there's no enough room for the pregnancy to grow up to 9 months in here. So for repeated pregnancy loss, usually 3 or 4 months, it loses pregnancy. Unfortunate situation, which in my career of spending over 40 years, I've seen only 2. It's a woman with longitudinal vaginal septum, which has got what we call vagina, where the other compartment communicates with the uterus. The other compartment does not communicate with the uterus. And in both of them, when I look at the diameter of both vaginal compartments, the one that does not communicate is the one which is large, which means sex takes place in this compartment which does not communicate with the uterus, while the one that communicates with the uterus it atrophies because of lack of dilatation by the penis. In that way, the general operation that remove this barrier between and make this vagina one is very easy operation. And one of them is woman. I know she is later fell pregnant after that operation. Condition of the cervix that causes infertility. One of the commonest notorious one is what we call cervical stenosis, stenosis of the cervix, which is the narrowing or closing of the passageway to the cervix. Cervix, I mean the lower part of the uterus, which is called the mouth of the uterus. Cervical stenosis often causes no symptoms. You've got no symptoms. You have to examine and see it. It may cause menstrual abnormality very rarely. It causes infertility, but if it's there, sperms won't be able to enter the cervix because it's tightly closes and stenosed. One that can make you suspect cervical stenosis is scanty prolonged menstruation, because when she menstruates, blood that comes out of here, they come and accumulate here because where they must come out, it's narrow. They trickle for over a long time, find that a person menstruates for 8, 9, 10 days instead of menstruating 3, 4 days. Well, the cervical, another component is competent cervix that doesn't close properly. The cervix that doesn't close properly doesn't cause infertility per se. It just causes mid-trimester pregnancy loss. That woman is fertile, but she never carried pregnancy term. About 4 months, 5 months, the pregnancy comes out because the cervix doesn't close tightly. The one that causes infertility is cervical stenosis. I had said that in those two conditions that I want to tell you about is major Rokitansky-Caster-Hauser syndrome, where the woman has got abnormality of development of the malarial system. The malarial system, that's where the ovary, the uterus, and the upper two-thirds of the vagina comes from during embryogeny. They don't have a uterus and the upper two-thirds of the vagina. They've got short, blunt-ending vagina. And the one feature about them is that they will have amenorrhea, they won't menstruate. The same as women with androgen sensitivity syndrome, testicular feminization syndrome. That I say women because they are read as women. But genetically, if you do a karyotype of these people, you find that they are 46XY. They are male, but they look like women. They're beautiful. They can even get married. So it's good that it's advisable that when you see a child 16, 17 years without menstruation, go and investigate quickly so that you can find whether you are not dealing with testicular feminization syndrome or major Rokitansky-Caster-Hauser syndrome. Because the earlier you start psychotherapy, the better, because the treatment of those things is psychotherapy. The major Rokitansky-Caster-Hauser syndrome, the whole red part is not there. Well, this is the normal uterus, you must have the normal uterus. So, laparoscopy. If you look at laparoscopy, majority of them we diagnose them at laparoscopy, of course. We look into laparoscope and find out that we've got a bladder here with the in the bladder, but there's no uterus. Then you wonder, this woman has got no uterus. If it's a major Rokitansky-Caster-Hauser syndrome, it will just be fallopian tubes and ovaries and no uterus. While testicular feminization syndrome will present with the carbonaculum and the undescended testes. They usually present with bilateral inguinal hernias. One feature about the major Rokitansky and testicular feminization, this woman is the woman with testicular feminization. They are tall, they've got increased carrying angle, they are muscular, because they've got testes, of course, they've got androgens, that's why they become muscular. And the treatment thereof is just to remove those testes. This is the picture that I took, which I removed woman with testicular feminization syndrome this year at Mankweng Hospital. And they has been from place to place. They think it's not a woman. This is the inside of the woman with testicular feminization syndrome. You can see the testicular vessel going into the internal inguinal ring, there is going to supply the testes because there's no scrotum. The testes, they lie just below the external inguinal ring. So she presented with inguinal hernia. bilateral inguinal hernia. And at laparoscopy, to pull it nicely, you see there's no uterus here. This is a part of Douglas. There's no uterus, the rectum. The bladder is up there. Then if you thoroughly, that's the bladder, what is pink, is urinary bladder. If you pull that ovarian vessel, pull that gonadal vessel, which is not ovarian, but it's testicular, you're going to pull out the testis there. That's the testis, undescended testis, laterally. The treatment thereof, because undescended, the reason why the testis is in the scrotum outside is that the testis must function at a temperature lower than body temperature. This one are subjected to a body temperature for a long time, and they're prone to have malignancy, to develop cancer. So that's why when a woman with a androgen insensitivity has got testicular feminization syndrome, the treatment is to remove it. This is the other testis on the other side. The treatment is just to remove those testes and put on hormone replacement therapy. With good psychotherapy, they do well. The cervix itself can have abnormality that is underdeveloped because you need a cervix of 3 to 4 centimeters with good mucus for sperm to be nourished and through the cervix for fertilization. If the cervix is short and underdeveloped, the semen is unable to ascend through the cervix. And that way you find that even after every sex, sperm just comes out. After every sex, sperm just comes out. And if it's underdeveloped and not perforated, it will give you what you call cryptomenorrhea. Cryptomenorrhea means hidden menstruation. Menstruation will not come out. You will develop that condition that I called the blood accumulate inside the uterus and cause hematometria. And such women usually present with primary amenorrhea. They have never menstruated and they'll have abdominal molds. Or they can have chronic pelvic pain from blood that trickles retrogradely through the fallopian tubes and irritate the peritoneum. I've talked a little bit about cervical incompetence, that it first flows tightly in pregnancy. And those women, I said, they are not fertile. It's just that they've got repeated pregnancy loss, especially in the middle of a trimester. They never came pregnant, so they are childless and they are classified as infertile because people in the community, they define fertility by successful pregnancy, but by definition, they are not infertile. It's just that the cervix doesn't close completely. And the treatment that I've discovered is what to do what we call cervical encerclage, which you can do interval cervical encerclage and put a stitch around the cervix so that it mustn't close. Or during early pregnancy, before 12 weeks, we can put a cervical stitch around there. And there are different types of stitches that we can do. We can put McDonald, can put Shirotka. There are different types of methods depending which method the doctor is comfortable with. The cervix has got a mucus inside. This cervical mucus changes in consistency throughout the menstrual cycle. Early in the follicular phase, the cervical mucus is watery. And more especially around ovulation, it becomes very watery. But in the progestogenic phase, after ovulation, it becomes thick. It becomes thick and viscid, from a operculum that closes the cervix. So if the mucus is thick and sticky throughout the cycle, around ovulation, you've got a thick mucus. Sperm won't be able to pass through it because you need to be thin and watery. And if the mucus is too less in quantity, because you need a copious amount of mucus for sperm to swim through it in the cervix to go into the uterus. If there's too little cervical mucus, it will restrict the sperm movement. And if sperm cannot move through there won't be any fertility. But sometimes the pH of the cervical mucus, or which is the pH of the vagina, if it's too acidic, because vaginal pH, my pH is acidic, but if it's too acidic, the sperm might not survive it. There's a condition which is called cervical mucus hostility. They say the cervical mucus is hostile. Usually they refer to a situation where the mucus of the cervix has got antibodies inside. These antibodies are called anti-sperm antibodies. These anti-sperm antibodies, once the sperm enters the cervical mucus, the antibodies attack the sperm and kill the sperms. So such way, you will never have pregnancy because the antibodies in the cervix killing the sperm. They call such mucus a hostile mucus. That's why condition is called cervical mucus hostility. How to test that cervical mucus is viscid or is watery? If it's fertile, you find that there's a test that they call a spin bagay. Take cervical mucus, see how much you can stretch it, because mucus should be elastic and stretch. If it doesn't stretch 4 to 5 centimeters, you know it's very viscid. You can even ask the patient to do it with a finger. You put the finger inside the vagina and come out with mucus around ovulation and see how wide you can spread your fingers before the mucus can break. If it can break about 1-2 centimeters, you must know that's not a good mucus. It's a very thick mucus. Or the doctor in the room can take the mucus and put it in the slide, 2 slides, and separate the slides and see how wide it can and measure that distance and see that you've got good cervical mucus around ovulation or not. There are various tests that you can do. Uterine conditions. I said I'm going to describe it anatomically as I go up. The common things occur commonly. Uterine fibroids are tumors that grow in the woman's womb. They are typically not cancerous. They are benign. They never become cancerous. They may not need to remove if they are not causing pain or causing any problem with their large or their outside. But if they are intramural or submucous, will probably compete with space, with the space, then be the cause of infertility. Or they are multiple, or they are large. Sometimes you can have endometrial polyps, which are polypoid structures that develop inside the uterus, which can be huge. And one of them that feature that you can say these are polyps, they cause menstrual abnormality. They are abnormal growth, and they contain glands and stroma and a lot of blood vessels in that. So this is why they bleed a lot. They project from the lining of the uterus, the endometrium, into the uteral cavity and cause occupy space there. They can grow large enough to fill the entire uterine cavity. If they are found during reproductive years, they need to be removed. Another condition, that condition, which is more common, is what we call adenomyosis, which is a condition that causes endometrial tissue, the tissue that you bleed every month, the lining of the uterus. It grows into the wall of the uterus, into the muscular wall of the uterus. So you've got the uterus that is bulky, usually globular in size. And every time you menstruate inside the wall of the uterus and enlarge it, which causes the uterus to enlarge as months go. And on ultrasound, the uterus is round like a ball. Normal uterus looks like a pear, is pear-shaped. And it may also lead to heavy, prolonged menstruation if there's communication between the endometrioma, which is adenomyosis, inside the uterus, and part of them communicate with the uterine cavity. You can have intermenstrual bleeding. Of course, uterine abnormalities will cause fertility, like absent uterus, if I've said. The fallopian tubes, usually, once a person is pregnant, we're going to check for the fallopian tube. Check the fallopian tube, whether they're open or not. The first step that they do, most people, is HSG. I've said fibroid tumors of the uterus. I've discussed them, and this is just a classification of fibroid tumors of the uterus. They are said they are non-malignant, they are not cancerous. If they are submucous, you classify, they say there's a submucous fibroid. They are inside the cavity, just beneath the endometrium, and that way they compete for space with the baby. Inside the wall, the body of the uterus, they are said to be intramural, inside the mule. If they are outside, just outside beneath the serosa, they don't usually cause infertility, they just cause enlarged uterus because they don't compete, except when they're next to the fallopian tube, they can strike the tubal entrance. But more often, if they're just on the body, they don't. If they're small, you can just leave it like that. Some of them have got a stalk that connected to the uterus. The stalk is called peduncle. If there's They're called pedunculated uterus. Unfortunately, fibroids are the one that develop inside the cervix, and the one that develop inside because more often they've got a peduncle and they cause sort of like cervical fibroid. It's common to have that, and it's called pedunculated fibroid. If you look at the picture here, this is a subserous fibroid. Just beneath the endometrium. It's sitting exactly where the baby is supposed to sit. So there will not be any conception. If there's conception, it will be early pregnancy loss, like this one. It's sitting where the baby is supposed to sit, inside the cavity of the uterus, while this one is intramural, sitting on the wall of the uterus. We'll see other fibroids that fibroid is left to grow. The reason for removal of fibroid is either the size, the symptoms, or the position. If the position is inside the wall of the uterus, like this one is intramural and is big, you better remove it because as time goes on, it will outgrow its blood supplies and undergo the process called ischemic necrosis and start to bleed inside. That's what we call, it will undergo necrosis. So before it undergoes necrosis, if pregnancy occurs like that generation is called red degeneration in pregnancy. Outside pregnancy usually can be bleeding, it can be calcified, calcific necrosis, which has got pain, but it's not as painful as a red degeneration that happens during pregnancy. You can even think the patient has got ectopic because she doesn't have ectopic. As I said, if it's outside subserous, it doesn't disturb the uterine cavity. Usually it's not a cause for infertility. The only reason we can remove it if it's too huge. Like here we see the fibroid, the uterus, the fibroid has got a stalk, it's pedunculated outside fibroid, which if we look through a laparoscope, you can find and discover it very well that this fibroid is a the pedunculator, it's got a peduncle, this fibroid. This is the uterus. With the magnification of laparoscope can be seen very well that there's no other fibroid. If ultrasound, there's no other fibroid intramurally, this woman doesn't have to undergo extensive operation for removal of fibroid, unless if the surgeon is conversant with laparoscopic myomectomy, he can just do it that particular moment, but it won't. And they usually become multiple. This is another one which is pedunculated side. And if you test the tube, if the tubes are patent, the fembrana are normal, this woman will carry pregnancy to term without being disturbed by these fibroids. So fibroids are not always the cause of pregnancy. Depends on the position and the size. But the size like this one need to be removed because it might just undergo degeneration. And if left for cosmetic reasons, they can grow and even resemble a pregnant woman. If you look at this woman, you think that this woman is pregnant, but this woman is not pregnant. She has got a huge fibroid which is sitting there. This fibroid of this woman, and I operated it, even published this fibroid in 2011. It's there. If you go and Google the largest fibroid, Daniel Mahapa, just on Google, the largest fibroid, Daniel Mahapa, it will come that article that I published in the Journal of OBGYN in 2011, because this is the largest fibroid that I've ever seen in my life. And many people have never seen a fibroid which weighs 13.2 kilograms in weight. And the woman is unable to walk because she's got this huge fibroid. After removal, then she's got taxi gait. She feels this is like she can fall, but after sometimes she recovered. So if it's not removed, the problem may be pressure symptoms and grow. The polyps that I talked about, I said they are pedunculated structures that grow inside the uterus. They compete with the baby for space and they cause menstrual irregularity. They need to be treated. They've got a stalk that attaches itself to the uterus and they need to be. And if a polyp is in the cervix, it will block the cervix and block the entry of sperm, and that contributes to infertility. Adenomyosis is easy. You can see it by menstrual irregularity, infertility. On ultrasound, you see lakes of blood inside the wall of the uterus. It will have intermenstrual bleeding, and it can also represent endometriosis that will give chronic pelvic pain sometimes can also give you hernia. This adenomyosis is a chronic condition that causes endometrial tissue, which lines the uterus, to grow inside the wall of the uterus and enlarges the uterus. They've got a huge enlarged uterus. Some people call it internal endometriosis because endometriosis, by definition, means endometrium in an ectopic site. So the endometrium inside the wall of the uterus is also ectopic. So it's an internal endometriosis. And it may make the woman difficulty in conceiving and cause disturbance daily life. Every woman's situation is unique. Although endometriosis may lower the pregnancy rate, it's not an absolute cause of infertility. It depends where endometriosis is. If it's focal on one side, the rest of the uterus doesn't have it. The chance of having pregnancy is like that. But the problem is if it's diffuse, the entire uterus has got endometriosis, then the patient cannot fall pregnant. That way it will cause infertility. In this picture, you see a normal uterus, but you see a uterus with endometrial glands that has grown into the wall of the uterus. Those are called internal endometriosis or endometrial adenomyosis, which can be minimal, can be worse, and cause bleeding, cause pain, enlargement of the uterus, and infertility. This is all that I'm seeing here as the variants of adenomyosis. Still on the uterus, we can have congenital abnormalities. Cervix can either be hypoplastic or absent. Tube can be underdeveloped or absent or hypoplastic, or maldevelopments of many parts of the female genital system. Let's start with this one. A condition where there is only one Mullerian duct present. Uterus becomes banana-shaped because uterus develop from left and right side from the Mullerian tube from left and right side. The other side doesn't develop. It's called a uniconnuate uterus, one side uterus. It's a rare condition which is partially the partial complete or complete lack of one Mullerian duct. It's got a typical banana shape, as I'll show you in here. And it causes either repeated miscarriage or infertility. Sometimes this, you can classify uniconnuate as non-communicating or communicating. If the cavity communicates with the main uterus, is communicating. If the rudimentary one does not communicate, it's called non-communicating because as it develops, the one that develops fully, it becomes the horn. The one that doesn't develop, it becomes a rudiment. And that rudiment can have a cavity or it can have no cavity. If the rudiment has got a cavity that communicates with the other one, it's communicating. But more often it's non-communicating. There's no cavity in the other horn or the rudiment. Like Slick sees here, there's a banana-shaped uterus, one horn. But this is a remnant, rudimentary horn. To communicate with this one, this is a communicative. This one, there's no communication between the cavity of the other main horn, which communicates with the vagina, and this one. This is non-communicating. The other one might just have no cavity at all, and the class 4, there's not even a horn. And when you look at this woman, it's got a cavity, but they don't communicate. It's even pedunculated. And if pregnancy occurs in the horn, communicating horn, then the chances are that it will be regarded as an ectopic pregnancy because it's going to rupture. That horn doesn't have enough space to enlarge. If you do a hysterosalpingogram, you see this banana shape will come like you see here, like banana, because the other one is sitting here, is not communicating, so the contrast media doesn't go there. It's very common uniconnuate uterus. Some people have got what you call double uterus, which is called uterus didelphys, which is a congenital condition where you are born with two uteruses. It's usually called polyuteruses. They can fall pregnant, but have premature miscarriages because of lack of space. And they present with prolonged menstruation because the two uteruses might menstruate at different times. Like you see here, you put one horn here, one uterus here. They all communicate with the vagina. They all have their cervix. If you've got pregnancy here, you end up early pregnancy loss or miscarriage or abortion. If we have menstruation, this uterus might menstruate day or two after this one. And then you have got prolonged menstruation because you are menstruating from two uteruses. The cone of the uterus also can be two. You still have one uterus, but instead of being a shape, it's shaped like a heart. You have a uterus like a didelphys uterus, that two separate uteruses with one cavity. It's more common than didelphys. One cavity here, one cervix, but the uterus makes like a heart. It's like this. This is a biconjugate. This is a normal uterus. Look here, there's a dimple in here. The operation for preventing this, to correct this, is called metroplasty, which is a fairly easy operation done early. These are classification. But normal uterus, didelphys, aquate uterus, uniconjugate, one cone, biconjugate with two cone, and a septum with septate uterus. Congenital abnormality of the uterus are very common, and if not looked for, they might just cause infertility. Like in here, you see there's a pregnancy in one of the biconjugate. Probably this pregnancy, if discovered, should be terminated early, about 32, 34 weeks. Take that baby out before it comes out, because the space here might not be enough. There are different methods you can do. On X-ray, if you don't have facilities for hysteroscopy, an X-ray, it can show you that you've got two horns here. In that way, it will be a biconjugate uterus or subseptate uterus. That way. It's a common thing that I usually look for them first, especially if a woman presents with menstrual abnormalities. Intrauterine adhesions, very common in South Africa, more especially after legalization of abortion. Abortion is good that it removes the pregnancy, but there's after effects thereof, it's infertility. And a woman who has had previous abortion, induced abortion, later present with infertility, psychiatry, they say she has got post-traumatic stress disorder. She regrets why she did that abortion, because with transcribing one after the other, there's subclinical infection. Always when I see women from the university there in Mankweng Hospital, they're using abortion as a form of contraception. 2 to 3 months a woman comes for, a girl comes for abortion. They're going to have this subclinical infection, which is going to form a condition called Sherman syndrome, which is going to obliterate the uterine cavity. And they are either present with infertility, implantation failure, or repeated miscarriages. And this can only be diagnosed by hysteroscopic examination, where you visualize and see the adhesions there. And you can even lyse them and cut them to restore the uterine cavity. The Asherman syndrome, the two walls of the uterus adhere to one another and obliterate the wall of the uterus. It's caused by this overzealous scraping of the uterus. And it follows most well termination of pregnancy. It inhibits implantation and causes reduced menstrual flow. So I think the adhesions of Asherman's can be either mild, moderate, or severe. If they are mild, they are partly occlude the uterine cavity. If they are moderate, the fibromuscular and completely occlude the uterine cavity, and they are supplied with blood vessel and bleed very easy. That way, the woman becomes amenorrheic, it doesn't menstruate, and it doesn't have babies. If it's severe, it's worse. It's composed of a connective tissue which is hard, difficult to even to liaise with the hysteroscope to restore the normal uterine body. If you look here, this is the picture of hysteroscope. You look inside, see a septum, you see the adhesions here. This is inside the uterus. Anterior and posterior are adherent to one another, but this is mild, not severe. They can bleed, but I like doing them with a cautery. With cautery, because it cuts and cauterizes, the Caesar which has got cautery. You don't get much bleeding. And if you get bleeding, after you put a balloon inside there, group the bleeding for 24 to 48 hours to succeed. We're using the laparoscopic Caesar here. Lias the adhesions that are caused by bacillus transcribing in order to maintain the cavity of the uterus. You just cut them. You just cut them so that you can have the cavity. There's another adhesion this side which need to be cut also. And then thereafter you find that the cavity is restored. So if there's implantation there, there's likelihood that that pregnancy will go up to 9 months. But with those adhesions, pregnancy usually doesn't go even up to 3 months. But very easily, it miscarries very easily. Sometimes even the woman is not aware that she has been pregnant because it becomes very early pregnancy losses. You can see how this uterus cavity is open very clearly. This is what you call adhesions of treatment. This is the treatment of Ackermann syndrome. Common and the most important one, disease of the fallopian tube. What are the functions of the fallopian tubes? It's a meeting place for sperm and egg fertilization. Sperm enters from the uterine side and egg from the femoral side. If they are damaged or functional impairment, will lead to infertility. And the commonest cause of damage of fallopian tube is sexually transmitted infection, especially gonorrhea, chlamydia. Of course, tuberculosis of the genital system can also cause pelvic inflammatory disease, but it is very rare. Tuberculosis, usually we find it in the lungs, but it can also have genital TB, which can be the cause of infertility. Before we go to tubal damage, let's have a picture of what is a normal anatomy of the pelvic organs, more especially the tubes and the uterus. The tubes and the uterus. That's a normal. There's no disease. You're going to be able to see the ones that has got a disease. You're going to appreciate them later. But these ones are different from the normal one that I've shown you. These normal ones, you can even do a pelvic survey and see the liver. Go back there. You can even test them by putting a dye in the vagina. If you put a dye in the vagina, it comes out this side. You put dye in the vagina, it comes out this side. It tells you that these tubes are patent. If the sperm can go into the vagina, it will come out on the femoral end. You can see this is what you call a blue test. You put a dye in the vagina and inject it, you push it, it comes in. That's a normal laparoscopic view. But with pelvic infection, you've got adhesions between the uterus, between the tubes, between the ovaries and the intestines, which will need to be liaised for you to restore the anatomy, because this happens in the anatomic relationship with the one that's going to cause infertility. Here, I like using laparoscopic Caesar with cautery attached to it in case I find bleeding. You liaise and try to restore the normal anatomy of the uterus. Then that way, sometimes at laparoscopy, if you want to see the severity, do a pelvic survey and look in the side of the liver. If you find adhesions between the anterior abdominal wall and the liver, those adhesions are called Fitzhugh-Curtis syndrome. It's usually caused by gonorrhea, chlamydia trachomatis. That means severe pelvic. Such women, you must just advise them to go for. If you find Fitzhugh-Curtis syndrome, you're likely going to find severe adhesions in the pelvis, tubal blockage, and then those women usually advise them to go for in vitro fertilization. If you look here, the pelvic infection, it doesn't choose how it does. Not only the tubes will be affected, even the intestines. You see here the intestine, the appendix, this appendix is adherent to the tube. This woman was to have appendicitis. Probably is going to affect the tube, and the surgeon might not be able to separate it and the tube. And it might just be fatal because appendix is pushed in a place where it's not supposed to be. Appendix, they use McBain's incision to remove it. This one, you can't remove it through the McBain's because it's in a ectopic area. Sometimes the intestine themselves, infection can cause intestine to adhere to the anterior abdominal wall, like you see here. If they're adherent there, they either cause intestinal obstruction. If they don't cause intestinal obstruction, if it's pregnancy or care, you'll have intestinal obstruction during pregnancy, which is a very difficult thing to treat. Or if it's severe internal, severe pelvic disease, you become infertile. The danger with this one is that when removing that intestine from the anterior abdominal wall, one should be careful not to injure the intestine, because usually small intestine, which is easily sutured. I usually try to remove it by cutting part of the anterior abdominal wall, but, reserving the most tissue on the intestine itself. And I pull down, like you see, when I pull down this one, it took me such a long time, but happily I found that I didn't injure the intestine, although I removed part of the serosa of the intestine. Removal of the intestine, which is adherent to the anterior abdominal wall, can be very dangerous. You must always have a general surgeon by the side in case you injure the intestine. But if you are careful, like I'm here, pulling the intestines away from the abdominal wall, piece by piece, moving and see what we are doing. If there's bleeding, cauterizing, you're really going to win and do that. This is that laparoscopy is not only diagnostic and workup in infertility, it's also treatment. You should see and treat at the same time. If you are used to, well trained in doing laparoscopic surgery. I must thank Mr. Johan van der Waal, the man who taught me how to do laparoscopic surgery. May his soul rest in peace. He was working in a plane, and this is the man who taught me how to do this. He's the man who organized for me go to Chicago to learn laparoscopic surgery. The intestine is removed away from the interior abdominal wall. Suddenly, you can cut with a laparoscopic scissor. And then you can see the pelvic vessels there. You can see the pelvic structures, the ovaries, and restore fertility. Treatment, investigation of infertility sometimes can be combined with treatment, although initially you don't intend treating. At the end of the treatment, you can treat. Then now we can see the ovary, we can see the tubes. This is what damage fallopian tube treatment is adhesion, is removal of the adhesion, either by salpingostomy with Bruhar maneuver, where you, if the tubal ostium is blocked, you can open it, or if the interstitial portion is blocked, you can cut it and throw it away and reimplant that tube. And that all this is microsurgery. You must be trained in doing microsurgical procedures. It's not a procedure that one can just do, but laparoscopy, advantage of laparoscopy in restoration of the tube, that it magnifies the tissues. If you look here, everything is magnified, and the omentum is adherent to the ovary there in the tube. The omentum is adherent to the ostium of the tube, is blocking the tube. It can be removed. And if removed, you test for tubal patency. And if like in this one, it was lucky, the fimbriae were still good. So we just removed this omentum from there and tested the tube for patency. And whether the tube was patent. Unfortunately, this woman, I can still say, she ate her within a year, she fell pregnant. So when doing laparoscopic evaluation of the pelvis, be in mind that treatment might be instituted at the same time, rather than to wake the patient up and say, now you've got adhesion, you've got to remove adhesion. It's diagnosis and treatment at the same time. In this one, both tubes were adherent. Omentum had adhered to both tubes, and we remove entire omentum from the tubes. You see the fimbriae, although they're not the best of the fimbriae, but they're still visible. So in the next slide, you see we will test for the tubal patency in the same patients. If we test for tubal patency in the same patient, you can see that put a dye in the uterus, comes out this side. Then you say, hurrah, chances that I'll have a good pregnancy. Unlike if you have a situation where the uterus, the tube is totally blocked. If you put a dye just occlude there and form a bulge in the tube. After doing this dye, you must wash thoroughly with saline because dye also can cause subclinical inflammation. But if it's totally blocked, there's nothing you can do. The only thing is just to do salpingectomy to remove that tube. Every woman who would go for laparoscopy must be warned that we might make your condition worse. Must be signed that should you find the hydrosalpinx, must remove it, because sometimes you remove a tube that of a woman that he hasn't agreed to removal. He claims you made it infertile. You might have to argue with a lawyer in court. And lawyers don't understand this thing. Their reasoning is very cockeyed. So make them sign for every eventuality, because you don't know what you're going to find. If you find a forest like this one, you, after doing extensive visualizes, you still find that the tube cannot, the function of the tube cannot be restored. What do? Because if IVF, she's going to go for IVF, she's got hydrosalpinx, that water of hydrosalpinx, if it trickles back into the uterus, it causes repeated abortion. The IVF specialist will request you to have that tube away. So explain to the woman all these scenarios and always make a video of the tube, video of the whole procedure, so that, and give to the woman that video, because women do doctor shopping. There's always a story of somebody having done miracles somewhere. She'll hop from one doctor to another doctor. The reason of doing a video is that if she goes to another doctor, because she wants these things, another doctor will tell her the first stories. The doctor must never repeat what you have. Because the tubes are very sensitive. They don't forgive any insult. Mild infection, it makes the tube and cause adhesions. And even the type of operation that we do on the tube, we don't respect the tube because adhesions. Must be at the use of fire, use of cautery. You see, we're using cautery here. That cautery is what you call thermal spread. It does not only where you are burning where the damage is, it will be damage beyond the area where you are burning. That's called thermal spread. So always try to minimize the use of cauterization, electrical cautery. Even if adhesions are hence, either use harmonic scalpel, EPC, which is upon beam coagulation, other modalities that does not dispose to much of damage. But this is a very wide condition, very common, and notorious cause of infertility, endometriosis, which is implantation of the endometrium outside the uterine cavity. I said implantation inside the wall of the uterus is called adenomyosis. And it can be on the ovary, which is called ovarian endometriosis, on the tube, which is called tubal endometriosis. Tube, I mean fallopian tube. That's in the peritoneum, or it can totally obliterate the pouch behind the uterus, which is called the pouch of Douglas or the cul-de-sac. And it causes dysmenorrhea, heavy, painful menstruation, very painful. And it causes painful sex. And all of at the end, the woman will be infertile. Sometimes you do an ultrasound with a woman with menstrual abnormality. You think you've got cyst. Initially, you don't know what kind of cyst is this. As you manipulate, you find that these are endometriotic cysts with chocolate cyst inside. They must wash that thoroughly because it might cause ovarian endometriosis and implant it inside this pelvis, and now you're causing pelvic endometriosis. One that usually is heavily cause pain during around ovulation is ovarian endometriosis, where we've got black spots on the ovaries, which by themselves, if they are not grade 3 or 4, they won't cause infertility, but they'll cause pain. So the best thing is just to go and remove it. You can't remove ovarian remnant at laparoscopy. Remove it, because if you don't remove it, it will just grow. And usually, if you see a small fibroid endometriotic like that, this is a tip of an iceberg. You might find inside the ovary, there's a huge endometriosis. And I like using harmonic scalpel because it doesn't leave a lot of scar, it doesn't leave a lot of texture, it doesn't cause a lot of adhesions thereafter. And it can remove it, take a biopsy with a margin of normal ovarian tissue for histology. In that way, you can help the woman to minimize pain. Endometriosis of this size will not cause infertility, but will cause a lot of menstrual pain and sexual pain. One that will cause infertility is the one that will obliterate the sac and form a hard band of endometriosis, which even when you move them or try to cut them, they are difficult, they are hard. The only way you can try to cut them is the way which is more risky, because you have to be careful and experienced in doing that. That if you want to cut them, you have to use an instrument, a scissor, and cut very hard. Beyond that endometriosis, you don't know what's sitting there. It might sit a rectum, there might be a ureter, there might be the upper part of the vagina. I always have an assistant with a finger in the vagina, keep on taking there to show me where I am, because as you see, laparoscopy is two-dimensional. That's a finger in the vagina. Then I know I'm still far from the vagina, so I haven't cut the vagina into the vagina, because sometimes can make a hole in the intestine or in the vagina. The easy one is the one that where you really have to cut the endometriosis, and you cut it completely because you have decided that with this amount of endometriosis, there's no way you can attain fertility. This woman should just go for in vitro fertilization. And for in vitro fertilization to occur, you need to remove all other pathologies that causes debilitating pain. Because if through a normal means, there's no way this woman with grade 4 endometriosis will conceive except through an in vitro fertilization or assisted reproductive technologies. But all this, you see, this one is when you have passed inside. All this, the patient must be told before the operation. Patients are learned these days. The hungry lawyers are there waiting for you. If you do it without telling the woman, she's going to claim that you remove a tubes without her consent and she wants a baby. You tell her, these are the possibilities. What should I do to avoid this? If you should leave it, take a video and show it. This is how you look like. You want to live like this with pain, you want me to go again and remove it. And if you go again, it's another charge. So most women will agree, if they trust you, that you must remove whatever you think is a pathology. Do whatever you think is the best for me. Ovary can have different type of cysts. Can be follicular cyst or corpus luteal cyst. Those are functional cysts. They have got no, they usually don't grow beyond 5-6 centimeters. The cysts that give problem are the neoplastic cyst, which are usually epithelial cysts, cell cysts, germ cell cysts, or sex cord cysts, sex cord or stromal tumors, which on naked eye might see others like stromal tumors, teratomas. But with the advent of 3D ultrasound, one can easily measure the cyst in the XY Z axis, which is orthogonal axis, even convert this axis into a 3D structure and see the structure, how the cyst looks like before you can go and remove it. It's important to transvaginal ultrasound and convert the cyst into a 3-dimensional figure, which you can even twist it around it and analyze it and see how it looks like, so that we can explain to the patient what we're going to do later. This is a cyst that you can turn it around if you want to turn it around, and it's exactly the shape of the cyst, how it looks like, and you can see it. So, but majority will resort to laparoscopic visualization of a cyst, which seeing it or palpating, if it's soft, it's either mucinous cyst or serous cyst. But if it's hard, it's either a teratoma or sex cord tumor. So this was a soft, you see, soft when it, but if it's hard, like this one, you know it's a teratoma. Teratoma, the treatment is just to remove it. It's hard. If it's hard, it will not cause, it will cause pain. And teratoma never become malignant, but if fertility is a problem, just remove it, because it's got hair and it's got bones inside it. It's got the heterologous remnants. So the ovarian cyst can come in different ways. But cyst by nature inside, it contains fluid. And if it's serous or functional cyst, it will contain watery fluid, which when you treatment, if it's causing pain, you just decompress it and leave it as it is. Although they've got a tendency of recurring, the good Lord is not so punished, doesn't punish women as such. It doesn't recur all the time, but it can recur. You never say never in medicine. But if it's mucinous, you might have to open a wide bore, even cauterize inside, because mucinous cysts tend to recur very quickly and cauterize inside. So if you did recur, there's an opening in there. And in the meantime, if you do ovulation induction, the woman can fall pregnant. The cyst assessment is one of the best ways to decide what to do with a cyst. When you go inside, you assess, you don't know what you're going to do. This type of the cyst, the position and the size to tell you what you must do with it. Majority of functional cysts, if they cause pain, because they will only cause pain, they won't cause anovulation. They will cause anovulation and pain to decompress it. But if they don't cause that pain, just leave it. In over 2-3 cycles, they will break by itself. Usually they are called luteinized and ruptured follicles. They are just Raffian follicle that has not luteinized. So only if the patient is approaching menopause or is post-menopause and she's got a cyst, this near or at menopause tend to develop malignant cancers. It's only that you can try to remove it. If she hasn't reached menopause, don't remove the entire ovary. Leave a little bit of the ovarian tissue for endocrine purposes. Like you see here, I'm removing part of the cyst, but not the entire cyst. I'm leaving the other process for endocrine purposes because I don't want to give this woman mature menopause, because menopause in itself, it needs its own management. So management of the cyst depending on the desire for the patient, the age, the type of the cyst, and the size of the cyst. And the decision will always be taken when you see the cyst inside here. When you go inside, the patient will be told there are several things we can do with it. The definitive management is decided intraoperatively. And after removing this, you send it for histology. If there's no cancer, you say, hooray, but you know that you haven't given the woman artificial menopause, early menopause. Thyroid disease, thyroid is a gland that is in front of the trachea. It causes amenorrhea also. The Cushing's disease of the adrenal can cause amenorrhea also. Kalman syndrome can cause amenorrhea also. The Cushing's disease can cause amenorrhea. Cushing white person will be fat with stria on the abdomen and big breast with amenorrhea. Very difficult to treat. Genetic conditions, I have said already, is testicular feminization and major syndrome, and Turner syndrome with Rh isoimmunization, where the patient has got antibodies against the Rh of the husband. That's why when you're pregnant, they take blood for Rh to check whether you don't have Rh isoimmunization. If you put Rh isoimmunization, then they have got to treat it first before, because otherwise you're going to form antibodies that will just kill those sperm. This is a typical woman that I did myself at Mangwe, that was having testicular feminization, and I removed these 2 testes here, and the woman is well. The investigation in that case is diverse. The first one, which you can do, even a general practitioner can do, is basal body temperature chart, which you teach the patient how to, every morning before he wakes up, it is a temperature. Just before ovulation, the temperature will come down. There will be an day. Thereafter, in the proliferative phase, which is progesterogenic phase, will be high. Somewhere in between here, ovulation has occurred. Important. Basal body temperature, you cannot use it to intrauterine insemination or to time ovulation. You only use it to see if the woman is ovulating or not. When he has ovulated, it won't tell you, but it can tell you somewhere in between the nadir, the peak. So if the last month body temperature was like this, you know this woman is ovulatory. You can buy ovulation kit that says ovulation what it is, or you can time the time of the second she has, and encourage them to have sex around ovulation. But it doesn't tell you when ovulation occurred. It tells you where ovulation occurred. If you do the hormonal profile, I said that the hypogonadotrophic hypogonadism, with low gonadotropins. The level of gonadotropins. In polycystic ovary disease, with inverse ratio of LH and FSH. Usually, mid-cycle, we've got FSH is more than LH. Because it's the other way around. You can test the ovarian steroid, which is progesterone and estrogen, if it's low. Like, for example, I've said previously that if you've got ovarian pathology, mature ovarian failure, the ovarian steroid will be less, and this woman will only conceive through egg donation or IVF. The thyroid also, I've said the thyroid can cause, molecular hypothyroidism can cause that. Prolactin level, we'll discuss it now. Prolactin is a hormone that's produced by the pituitary, which, if it's high, it causes milk secretion, its ovulation, and cause infertility. That condition is called galactorrhea, which is a milk discharge from the breast, which is very common in women. It can be caused by stress, as I've said. Investigation, the basic investigation that everybody should do, even a GP, is an indirect visualization of the fallopian tube by X-ray. It doesn't give you a direct diagnosis, but it yields a presumptive diagnosis. You can say it seems like things are like this. It's easy and expensive, and it's an outpatient procedure. Incidentally, most women will conceive after HSD because if the tube is blocked by mucus plug there, when the radiographer put HSD there, it might just push that mucus plug like hydrotubation and open that tube. She becomes pregnant, but you can't use HSD as a means of infertility to say that I'm going to unblock the tube. But if it unblocks the tubes, it's a bonus. This is early X-ray, this is late X-ray of a tube which is patent. We see the contrast media into the peritoneal cavity. Laparoscopy is what we have been seeing all along. Assessment of the fallopian tube, we have assessed normal. This is the quality of the tube of the femora and exclude other pathologies, adhesions, endometriosis, and PID. And tumors, you can even assess them through laparoscopy and treat them. The patency of the tube, we tested it by means of a blue test that we have seen previously, that if you inject the dye inside the uterus and it comes out through the tubes, you know that that patient has got patent tubes. If ovulated, or if she's ovulating and the male doesn't have a male factor, he will fall pregnant. This is the dye was injected inside the vagina. So it means if you put sperm in the vagina, it will come also this side. Medical, people who don't ovulate, we use medicine for them to produce egg. There are several ones of them. And it depends what is the cause. If the cause is psychological, affect the hypothalamus, you must treat them by psychotherapy. So infertility is a joint treatment with psychologists. Because an elevated androgens, we have to suppress the androgens. I'll show you the picture of a because which is on another slide or not in here later, which is a modern way of treating it, but also there are medication. You can also treat it by medication. Thyroid, so is thyroid in conjunction with a physician. And obesity associated with hyperandrogenism will give you virilization, also be treated. And body weight, I said you must control weight. This, if hypothalamus concentration of gonadotropins will be low, and weight and exercise related amenorrhea is very common. Women who frequent exercise too much are likely not to ovulate. And then we have seen that pituitary tumors, in conclusion, also can give you that. And ovarian, more especially, emphasis on polycystic ovarian disease, which will increase the number of androgens, the inverse relation of LH and SH. They've got insulin resistance. These women, as time goes on, they will develop type 2 diabetes because of this insulin resistance, which is a long-term risk. They've got hair, beards, endometrial hyperplasia, and if they're obese and hypertensive, they're the one that develop endometrial cancer. We can treat them with ovulation induction, with or without ovarian drilling. At the end of the day, I'm going to show you a picture of video of ovarian drilling. Artificial insemination is something that even a GP can do. Who qualifies for artificial insemination? Patient with cervical mucus hostility, because I've said that the sperm, when they pass the mucus, they kill the sperm. This cotton HIV couple, if one is a couple, one is positive, one is negative, you don't want them to engage into unprotected sex. So the only way they can fall pregnant through the habits of sperm is artificial insemination. You take the sperm from the husband, send to the laboratory, wash, concentrate it, and bypass it, put them in the uterus. The lesbian couples don't have a penis. Go in the laboratory and ask for donor sperms, and you can do artificial insemination. If there's a male infertility, a man does have got sperm which are weak. They need to be concentrated and washed, injected inside, because through a normal she cannot. And it's a very easy procedure.
IUI, or intrauterine insemination, is timed around ovulation. A fresh or frozen sample of sperm from a partner or donor is processed, being centrifuged, washed, and then concentrated. This greatly improves the chances of fertilization, as the post-wash sample has a higher concentration of live and active sperm. The IUI procedure will be performed when the sperm sample is ready and prepared. A speculum will be inserted so the cervix can be seen. A soft, thin catheter is placed through the cervix into the uterus. The washed sperm is then injected through the syringe. The IUI procedure will only take about 10 minutes.
It's a very common procedure. Of course, I will not go deep into assisted reproductive technology. It needs a webinar on its own. I think somewhere during this year, I'll make a webinar on assisted reproductive technology, which include IVF, which is in vitro fertilization, gamete intrafallopian transfer, which is called GIFT, zygote intrafallopian transfer, which is called ZIFT, intracytoplasmic sperm injection, which is ICSI. These are all high-tech assisted reproductive technologies that we'll just mention them here to pass. If I were to discuss them, I'll discuss them as a webinar on their own. Now the question, we know that we are in South Africa. We are African, Black. The majority of Africans are poor people. All these investigations involve money. The government facilities are not sufficient enough to cover the number of people. They don't have enough manpower, enough. Only few government facilities got infertility centers. I know in Gauteng, Joburg and Steve Biko. Mpopo has got none. Mpumalanga has got none. So a few, and they are overwhelmed. What is going to happen for the poor people, poor couple? This must be discussed when you discuss the question now. Conclusion, I'm taking you to real life situation. Because if you don't have money, you can't. You know, since 1994, the life of a black person becomes worse than during apartheid. Example I can give is that the apartheid government were building houses for people. They put them 4 rooms. During the struggle, we used to say they are matchboxes, but they are worse than houses that are being bought now. If those are matchboxes, these are matchsticks. So which means the life of a South African black from 1994, from democracy, has gone worse than it was before during apartheid. That's a fact that you must consider. I'm looking at these houses only and other things. Besides that, majority of people in South Africa are living in shacks. If you are living in a shack, can you afford IVF? Can you afford laparoscopy? Can you afford gynecological examination? Can the state hospitals, they can't afford to treat them, all of them. So people in Mpumalanga and Limpopo, what happened? Whenever quit. It doesn't only affect the lower echelon. We find that people, graduates, we have got graduates in South Africa who are not working. No work. Industry, nobody want to invest in a country which is full of crime and the parliament is full of crooks and thieves. So you find graduates like this who can read a smartphone, they can read about infertility, they can know what can be done, but they've got no money. What must happen? You find that some of them they can even Google and in the computer and see how this can be done. But the problem is, where do we get money, darling? Infertility doesn't start now. Africans don't start living now that South Africa is colonized. We've been having infertility and we knew how to approach it. How do you approach it? I want you to let's look at to say that infertility doesn't start now. What does the Bible say about infertility? Because I like referring to the Bible because Africans, they are more religious than the people who brought the Bible here. You can fill up the whole show ground, waiting from 4 o'clock, waiting for Bushir. The people who brought the Bible here never do that. What does the Bible say about conception? From his instruction of God to Adam and Eve, he said, be fruitful and multiply, which means it's godly, multiply. He encourages that. In Psalm, this is said in Genesis 1:28. In Psalm 127, from 3 to 5, but it shows that having children is God's promise. It's good for us to multiply. And he says, children are a blessing. We interpret it anyway. They are just blessing. It's not a must to have a child. It's just a blessing. Even if you are infertile, you can still marry. I'm not sure. The Reverend will have to explain to me when he says blessing, what does it mean? But in Timothy 2, 1 Timothy 2:15, we can see that desire to have children, this is God. Now, going into the history, there's a woman called Sarah. His husband was Abraham. Sarah was infertile. He had infertility until he became very old. And he took a slave girl called Hagar. I must put a point here. In our Lutheran church, they used to have a Hagar campaign last year, and they misinterpreted this point. Hagar was not Sarah's slave. He was just a slave girl there living. There were slaves there. And the slave girl that Sarah liked and said, marry Hagar. Not to say it was Sarah's slave. It was a slave girl in the vicinity because there were slaves in that vicinity. He called Hagar. Hagar slept with Abraham and produced Ishmael. But to surprise, later Sarah also fell pregnant. Masru is a child who is born when the mother is very old. Sarah made a latlameki, but Isaac, which means this tells us that you never give up in infertility. You can have a baby very late. Isaac, that son of Abraham and Sarah, that latlameki, also had a wife, and the wife had infertility also. But his Bible doesn't tell us whether William Nyakela he looked for Rubina, because Hagar, Abraham, we call him Kasutuwar Tazadiru. I want to tell that the Bible and the Africans were doing the same thing. But if it's African, they say the Bible did the same thing. Hagar was Tazadiru. But Rebecca didn't, that Bible doesn't tell us what they look for Tazadiru or not. But later, he gave rise to twins, which is Esau and Jacob. Of these twins, Jacob also married Rachel. Rachel was infertile also. Infertility was in the family. Rachel gave a sister. It doesn't tell whether it's a sister from the same mother or it's a sister, because a sister can be a distant relative. But I think it's a sister from a distant relative. This is found in 2 Samuel 13. He gave a sister called Leah to Jacob. He said that this sister was not so beautiful, but he gave it to Jacob. And also gave another one, another one called Bilhah, Jacob, to make children. This is the woman's job. Look for the substitute woman. Bilhah gave birth to Daniel and Naphtali with Jacob. And they all looked after they were proposed by Rachel. And Leah gave birth to Zebulun and Dinah. That is great. Sometimes later, Rachel conceived a lad Lamech called Joseph. So when you look at the Bible, the children of Jacob, about 12, Joseph was the one who was hated because he's the one who is really the gene of Jacob. All these others come from what group. So they teamed against him. Went to Egypt of the guy who gave them, he was loved by the father. Because he's loved by the father, because this is the one who is really the real child of the father. So I want to show you this, that Africans and Bible have been doing the same thing. And then during discussion, I want you to tell me, what must we do with the poor people? Just listen. You must listen to the elderly people when they talk. Don't just because you've read the books, we'll listen to you. Listen to this one.
Mosadi ha sa etse bana a ka kgona hore mosadi eo a nyale mosadi o mong kapa monna a nyale mosadi e mong
ha o ntse o phela o sena bana o bua le mosadi le mosadi yona a o shebela kgarebe ye ka ka toke
mosadi a lo ferela
bana a tlele yena mona bana e be yena a ilo ntsha dikgomo mane a o nyalle kgarebe mosadi
am ferela ba nyalla
ba o nyalle a tsamaya le mang wa leloko la hao e leng ka ngwane kapa e leng malome wena o dutse mona
ba bitla ke batla eng
ga ke batla eng wa bale a monyale a tle bana tlo tla dula mona ba dula ba le babedi le ngwana a hlahang wa pele ke ena monyale fa e a tlo butswa ke mmeno ka mane.
Ladies and gentlemen, this is how far I thought I should go with you. This is the time that we can discuss. Don't ask me many questions. I would like to have contributions. That's why initially I went to the African way. Should we do? I'm prepared to ask many questions, but I would appreciate if there are doctors here who meet these things every day, every time, and contribute to this. I've said infertility is a wide topic. Let me just make you unmute yourself. I think I've made you to unmute yourself. You can unmute yourself when you talk. How are you, gay? Somebody unmute and greet. I'll call you by names. Let me look for them. Lefa, how are you, my daughter? Am I audible? Lefa? Am I audible, people? I think I'm audible, and I made you to unmute yourselves. Okay, let me look for somebody that I can.
You are very audible, Doctor.
Okay, you just don't want to greet. Good morning. Let me greet my friend of mine. This man, we qualified together, we studied together, we wrote the same exam we wrote together, and we must do things together. Dr. Amogo, how are you? Amogo? Oh, he doesn't listen. Let me look for other people here. I'm scanning through you. I can see people here. Okay, Sam. How are you, my friend? Nugan. Unmute. I can't hear. I see you are muted.
Well, thank you, Dr. Mahapa. This is a very important topic. I've retired, but do Tuesday's gynae clinic at Dr. George Mukari Hospital.
Oh.
Majority of patients we see there because of infertility. Sadly, many of them have been left not well investigated. Last week I saw one who's already 50, a few weeks back, 53-year-old. So you're quite right that we're seeing this problem. The second point to make is that unlike during the olden days when we were training, that tubal damage was largely due to PID, currently we see a lot of endometriosis. And you've eloquently addressed this issue because indeed, so would urge that our doctors out there, basic investigations. You see a patient or a woman coming, the couple rather, coming for infertility, basic workup quickly must include pap smear, HIV. At least those are basic things that we need. Then you do all the tests that Dr. Mahapa has talked about. Tubal patency, we start with outpatient HSG. We do ovulation tests. Of course, with us, mostly still doing day 21 progesterone. The test where you showed the mucus test, it's important, but we hardly do that in the public sector. Once we have done tubal patency, is the woman ovulating? The third one is the husband fertile? Semen analysis. Now, I like your conclusion because we sort out when you send patients here. Unfortunately, George Mukari, we don't have facilities. We tried, but the province refused and said you must use Steve Biko. Currently, when you send a patient at Steve Biko for infertility, they demand something like 46,000. So you find that a poor woman cannot afford. And I think the points that you are raising are so important. We should be aware of that. In an African way, if that woman tubes are patent, there's ovulation. Our old ladies used to say she must go to another man and whisper to her in privacy, so that if the other person has failed, I mean the other man, the husband has failed, the other man is there to prove. And they send usually to somebody they knew is very fertile. Now, during your presentation, somebody asked, what's a normal FSH, LH, etc., prolactin? I think we needed, that point is just to say the laboratory, because it's often laboratory based, and they must give you figures, what you are looking for, and in brackets, put what are the normal ranges. And I think Dr. Mahapa can address that issue. But thank you for a very nice. I used to work with an old man at St. Augustine. It's a private hospital, top private hospital in Devon, and he did all those IVFs. Gift is one of the very successful procedure. Then you have intracytoplasmic injection. He brought the German guys who came to South Africa to teach South African doctors on intracytoplasmic injection. And I found it, again, those are high tech. For the purpose of this talk, we shouldn't go too much into, but it's a basic workup and when to refer. The role of laparoscopy. Thank you, Dr. Mahapa. You highlighted the importance of when you do laparoscopy, hydrotubation is or chromotubation, where we introduce the blue methylene blue test or dye. We want to see, is the tube patent? But it gives you ability to assess tubal health, not only patency. 2, are there other diseases like endometriosis? 3, how are the ovaries? So that if they are cysts, exactly how you did. We operated on a lady who works in one of the stores at Colonnade. This afternoon, they were scolding me because it was huge endometriomas. With Dr. Mnisi, we did laparotomy, the way they were huge. Stripped the ovarian cyst, chocolate cyst, trimmed the ovary to very little, but surprisingly, almost a year later, it has recurred. And I was saying, these are things that we should be sending to Mahapa and deal with it. But thank you for a succinct...
Thank you very much, Prof. Munukwani. Thank you very much. You never retire.
Yes.
You never retire. As long as you've got knowledge, you'll never retire.
Absolutely.
I'm going to choose now like a teacher. Got a classmate.
Yeah, Ntate Mahapa.
This is
Brasem, thank you very much for the topic and that input from Brasem. Very interesting that you have to send people to Steve Biko and they still have to pay those money. I mean, you mentioned that people are poor. Infertility is frustrating, especially for GPs, because people come there and give you a long story of this and that, and you don't know what you can do. That's the problem. Remember, Bara doesn't offer any infertility services. Helen Joseph doesn't do that. Charlotte Ngatlige, they might be doing that on a research basis, but not readily available. So if you're around Joburg, we send you to Steve Biko, but you must have the money. I mean, in the private sector, is a bit difficult because you have to pay for all those endocrinological blood tests. Maybe an HSG must be indicated, heterosalpingogram might be indicated. And you need to see a specialist gynae, who are also not affordable to, people who are not working. So it's a big problem in South Africa. So you might end up, maybe if you can say the woman's tubes are okay, the uterus is fine, and you find that it's on the men's side, especially the sperm analysis. You might go the olden way and say maybe to look for somebody to solve the problem. I think that's where we're going through. Now, I don't know, with a woman, as you said, they must also look for another woman. That's the only way to solve the infertility problem in this country. The thing of say you'll go there, look at IVF. People say they pay deposit of 80,000. That's not the whole cost. It's a deposit. It's just like a lawyer when they say, no, pay a retainer. You might get change, or most of you don't get change. They add and add until you just give up and say, let me just go and see. The other thing maybe also, there are many children who don't have parents, like young girls who live, just deliver and say they don't want a child. Maybe adoption also might be one of the things we should consider. Thank you.
Thank you very much. Let me enter here. Prof. Monokwana said about it, Dr. Matanda said about it. Last time we discussed male infertility, which the African treatment was to Rangwane Zen. But this time I'm showing the Bible. In the Bible, the woman is the one who goes and proposes. Don't go and look for a nyazi yourself. The woman goes and proposes. The wife for you, I want to hear from these women who are here. It need to be done. Because some women, if the husband comes, has got a child outside, and that they can say, go and take that child of yours. Let it be him be our children. If the mother is married there, then can give the child. The same way as if we marry a woman with a child, you take that woman. A woman will probably accept a husband's child from outside the relation. That's one way. It's not a solution. I think we have got a lot of people that can contribute here. David Mushuri, how are you? I must tell these people that David Mushuri was my classmate. We passed standard 6 together, MBCHB together. But he is a big doctor there in Kareso. David, how are you? Where is he? David, unmute.
Okay, while David is unmuting, let me just also add, Dr. Mahapa, I think the role of Clomid must not be undermined.
Ovulation induction.
Yeah, for ovulation induction. At ordinary level, we do HSG, tubes are patent, woman is ovulating, at least try, put the woman on a, we say 6 months, but 3 to 6 months trial of Clomid. I've got about 4 or so staff members, nursing sisters. One of them got twins, the others got 111, but all Clomid. And there are times where Clomi doesn't work. You give it, and they gave up for over a year, came back, repeated, and they went on to fall pregnant, 4 of them. So I'm just saying, and this is just in 2023. So a lot of people have had successes. All I'm just saying is, for once you've worked up the patient, tubes are patent, because that's the crux of the whole thing. Even if there's no ovulation test, at least try her on Clomid once the tubes are patent. Thank you.
Thank you. Somebody mentioned that there are a lot of children these days that the mothers can't afford to have them. They want to give them for adoption. I see you've got a pediatrician here who's a friend of mine. But I want to see whether in their pediatric practice, do they have mothers who really feel this child I shouldn't have had? If I've got somebody who can take this child from me, I'll be happy. Mfundo, how are you? Mfundo Kuzwaya.
Hi, can you hear me?
Mfundo, how are you?
Hey, I'm okay, man. How are you? Lovely,
Hi.
lovely presentation.
Yes, but you are a pediatrician. Mfundo Kukuza is a pediatrician, a friend of mine in Victoria. They see these children much and they see from neonates. We can air his view whether they've got these children that are stuck with the mothers and they're neglected. And the mothers say, if I had an option, this child, I would have aborted her or I would have given her for adoption. What's your take, Mfundo?
Yeah, that happens fairly frequently. Already this year, I've had one where we've had to contact the adoption services, social workers, and psychiatrists, and put together a formidable team to solve the problem. But that is an avenue that is often used. Actually, we may think it's not often, but because it's shrouded in secrecy, it's difficult to estimate. But as I say, already this year I've had one where we've had to go through the process. So it's an option for the couples that are unfortunate in that sense. And it's a viable option, especially among other race groups and elsewhere in the world. It's something that is done, but it is tightly controlled. There are acts and laws and regulations that one is going to go through, which differ from region to region. But it happens, although in privacy or secrecy, but it does happen. We get that quite a lot.
So this gentleman, I just wanted to show, it shows us that treatment of infertility is multidisciplinary. If they want a child, many children are there in pediatrics, get in conjunction with your pediatric colleagues, get in conjunction with your social workers. Then it can, as you say, it's a teamwork. Infertility is a teamwork. It's not a gynecological work alone. Thank you very much, ladies and gentlemen, for this contribution. I'm very thankful that this. Hello?
No, I think just in parting, let's support. I like what Mfundo and Dr. Soli Mutlante said about adoption, something we neglect. But indeed, we should be encouraging couples to say, look, we've reached the end, but this is not the end. There are options of adoption, and encourage it. Black communities or Black families have been reluctant when one has worked within the Indian community and whites. They just go for adoption. But within our Black community, of late, yes, we're seeing some consideration, but even then, it's still very low. So we should, as clinicians, healthcare workers, encourage adoption as an option. Thank you very much. Good night. Thanks, Dr. Mahapa.
I agree more with you. That's adoption. You know, Sam, when I grew up in a rural area. There's no family where there's no somebody who's staying there who's a distant relative or somebody. In my family, there's always somebody staying there with us from another family.
Absolutely.
And when we're treated like us, which means it's in the African culture to grow, it takes a community to raise a child. Adoption should not be a problem for an African. I'm sure wherever you grew, As a cousin of yours who's a distant cousin who was staying with you there. If they punish you the same. Your father.
Yes,
like that.
absolutely.
So adoption in African should be very easy.
Should be very
You
easy.
can talk this. I'm very happy that we have been here. My Zoom gave me problem initially, but we succeeded. Thank you. I'll stop here.
Okay, good night. Thank you.
Thank you, Dr. Mahapa. Thanks, everybody.
Thanks.
Good
Thanks,
night.
Professor. Yeah,
Thanks, everybody. Cheers.
sure.